Good morning, everybody, and welcome to our event this morning. My name is Jessica Springstead. I am the president of ATSNJ, and I'm happy to welcome on behalf of RWJBarnabas in co-partnership with ATSNJ for one of our regional events. Not that I really wanted to suggest another talk about COVID, but I do think there's some great information that will be coming out of today's lecture and pertinent as just yet another update as we pass through these next steps. So this morning I just wanted to go through a few things and then I will introduce our director. So we do have some events coming up throughout the ATSNJ. Those of you might know there is another virtual event this Friday morning at 8 a.m. That JAG will be hosting. So if you want to look out for that information, I believe you can actually still register through till tomorrow. We are also looking with our central rep to be hosting another JAG virtual event on June 17th. So look out for some information on that you'll see from Kate Zimmerman, our central rep. And then a couple of a little bit more global events. We are really excited to be able to bringing back our student workshop with the high school students, which will be hosted at Kane University in May on the 24th. You still have a few days to register. So if you haven't been able to do so or still working on those details, you do have until April 10th to register. We're looking forward to having the students come back and get them excited about our profession and hopefully have some future colleagues in the making. And lastly, we will be able to host our golf outing again on July 13th, and more details to come on that, but just wanted to keep your eye out for that. We had a great event last year, and looking forward to seeing the support again. For those of you who don't know, your representatives, we kind of made this a joint venture since it was virtual. So Justimer is your northern representative for those of you in the northern region. Kate Zimmerman is your central representative for those of you in that area. And then Carl Lang is your new southern representative for those of you way down South Jersey. Hopefully you're out there listening to us, and welcome to everybody. So thank you for RWJ with partnering with us, and we're excited to get the program going. So I would like to take this time to now introduce my boss, Diana Toto. She is our Director of Sports Medicine and Business Development for the Matthew J. Morahan III Health Assessment Center for athletes at the RWJ campus in Livingston. So really excited to be working with her, and we have a great panel of physicians who are giving us some excellent information. So Diana, I'm going to hand off to you.
Thanks, Jess. Thanks to everyone for joining us for our program update for return to play in athletes with COVID-19. We are really excited to, bring this program to you. I've had the privilege of working very closely with our panel throughout this very painful pandemic. I want to say I think we're surviving, or we've survived, but I don't want to put my foot in my mouth. I'm sure there's still a little ways to go here. But certainly I was in the grind with these gentlemen through many long days to try and accommodate our athletes, and they are just so super fantastic. So I'm really excited for them to be here with us and give us some updates, as I know they've been, readily in the field and helping us evolve our sports cardiology work within RWJBarnabas Health. So I'm going to start by introducing our sports cardiology co-director team for the system. Dr. Jeff Lander has authored the American College of Cardiology's pre-participation cardiovascular screening for adolescent and young athletes module. He's published several articles as well as presented multiple research papers on a national level. Dr. Lander frequently lectures, is actively involved in teaching and providing talks for the American Heart Association, and is the president of the New Jersey chapter of the American College of Cardiology. He's the team cardiologist for Seton University. He also consults for the New Jersey Devils. He's consulting cardiologist for Rutgers Athletics as well. And he is the co-director of sports cardiology for RWJBarnabas Health and co-medical director of the cardiac care unit for Cooperman Barnabas Medical Center. We also have joining us Dr. Anthony Altobelli. Dr. Altobelli is chief of the Medical College of Dr. Altobelli is the chief of the Cardiovascular Disease and Hypertension Division of the Medical Service at Robert Wood Johnson University Hospital, New Brunswick. He is a clinical assistant professor of medicine in the Division of Cardiology at Rutgers RWJ Med School. He serves as co-director of sports cardiology for RWJBarnabas Health and as a cardiology consultant for Princeton University Athletics and Rutgers Athletics. He's also a fellow of the American College of Cardiology. Good morning, Dr. Lander and Dr. Altobelli. Thank you so much for joining us today. And then I'm going to move on to our first speaker of the day, which is going to be Dr. Krzysztofiak, to provide some updates on COVID-19. Right before I do that, just a quick reminder, there is a Q&A function in WebEx that we'd love for you to utilize. You can send questions to all panelists. Please don't just send them to the host, send them to everybody. There will be a very engaging panel discussion with our folks today, so that will enable them to see the questions that are coming in. All right, so moving right into it, we're going to get started with Dr. Krzysztofiak. Dr. Krzysztofiak is a sports medicine fellowship trained and primary care as well. He's involved in the education of medical students, residents, and fellows. He is the director of sports medicine at the Barnabas Health Ambulatory Care Center, and he's also the medical director of the Matthew J. Morahan III Health Assessment Center for Athletes. He's a Rutgers Athletics assistant team physician, and he's clinical assistant professor also at Rutgers RWJ Med School. I get to work almost day in and day out with Dr. Krzysztofiak. You are in very, very good hands. I'm going to let him take the show from here.
Great, thank you, Jess and Diana, and big thank you for Dr. Lander and Dr. Altobelli for joining us today. Hope we can give you guys some really good updates. Much needed updates. Again, like Diana said, please use the chat function for questions. You don't have to wait to the end. You can keep them coming, and then we'll kind of triage them from there. I'm just gonna share my screen for my presentation, and then we'll get started. Great. Okay, so just starting off, we're going to be going over COVID-19 cardiac considerations and updates. I have no disclosures. Overview, going to be going over current CDC recommendations for isolation in a positive COVID-19 individual. Review symptom severity because that's critical for reviewing what we're going to be doing from a cardiac standpoint and return to play standpoint. Going over some updated consensus recommendations in regards to cardiac testing and progression. Talk about the importance of graduated return to play, and then we'll have a panel discussion and plenty of time for Q&A. So just to start off, likely everyone on the call knows about this, but I think it's a good reminder because it really sets the stage for pretty much what we're doing. So CDC isolation after a positive C19 test, it goes as follows. If you have a verified COVID-19 student athlete or any athlete or any individual really, but we're focusing on athletes today. Basically, if you test positive and you have symptoms, regardless of your vaccination status, you're considered a positive C19 individual, and that goes if you had a prior infection before. Multiple individuals have had COVID multiple times. The recommendations are stay home for at least 5 days. If you're around people in your home that do not have COVID, you should be wearing a well-fitted mask, and more importantly, just staying away from them. And there's no travel within that time frame. So that's your 5 days from COVID-19 positive test or when your symptoms start. Calculating isolation, there's been some debate about this, but what the CDC recommends is that your day 0 is your first day of symptoms or positive viral test. Your day 1 is your first day after your symptoms developed or your test specimen was collected. So again, that's 5 days from that time period. Ending isolation after you had symptoms can be as early as 5 days if the following occurs. If you had no symptoms, you can be in isolation on day 5. If you have still have symptoms, you're going to stay in isolation to either you're resolving symptoms or you're at least symptom-free without a fever for 24 hours without using a medicine to stop that. There's some recommendations that if you have a weakened immune system, immunocompromised, or significant symptoms, which may or may not prompt a hospitalization, you're likely going to isolate for up to 10 days. After you're released from that isolation phase, you should be in a precautionary stage up until day 10, where you should still be wearing a well-fitting mask for up to 10 days when you're pretty much around anyone or in public, and you shouldn't be really going to public places when you're unable to wear a mask. That becomes a little problematic if you're a student athlete who ends isolation on day 5, and the question is, well, can I be around my team from days 5 through 10? And we'll get into that a little bit later. Again, during that time frame, again, this could be applicable for more the collegiate athlete or professional athletes, but the recommendations are do not travel for a full 10 days after your symptoms started or your date of your positive test. So really just critical concepts or time frame. That's the current CDC recommendations pretty much as of this morning when I rechecked, and they become really important when we're talking about symptom severity and then going forward with cardiac testing and return to play. Symptom severity review, there's a lot of different information out there about putting people in different classes of illness severity. A recommendation from our health system is just pick one that's reliable and stick with it. This fluctuates a little bit. This is the one that we're currently using for our athletes that we're associated with from a contract standpoint. But again, this can fluctuate. But again, I think it's all about consistency. So by definition, asymptomatic is simply that you have a positive COVID-19 test and you have no symptoms. Minor symptoms usually include low-grade fever, cough, mild fatigue, upper respiratory symptoms, which are really popular amongst the Omicron variant, and you can have some light GI symptoms as well. Moderate symptoms is usually when you have a persistent fever over 100.4, and persistent fatigue for at least 7 days duration. You may have a pneumonia associated with it. You may have significant chest pain, activity limiting, shortness of breath, palpitations, and possible syncope. And these are going to fall under your more moderate symptoms. Severe is when you can either have hypoxia, need to be in the hospital, need oxygen, significant involvement of your infiltrates on your X-ray, or just symptoms that are just clearly just more severe than mild and minor and moderate. Critical is going to be more of your ICU patients that require respiratory failure and they may have multi-system organ dysfunction. These are really the sickest of the sick. Some updates. So as of a few weeks ago, there's a new update from the American College of Cardiology. They released a 2022 consensus update on C19 for cardiopulmonary sequela in adults. So I'm going to spend some time with this chart because this is what the cardiologists are going to be adopting moving forward. So now we have an individual, we have an athlete who tested positive for COVID-19. They're in their isolation phase based on updated CDC guidance. You're using your criteria for symptom severity, so you know if they're asymptomatic or mild or moderate, or if they're severe. And now this is what, again, Dr. Lander and Dr. Altobelli would be using to now triage. Now we have an individual who comes in who's COVID-19 positive, and now let's just say that they're asymptomatic. Looking at the algorithm, the new recommendations based on consensus will be training may resume after 3 days of exercise. If you have mild or moderate symptoms that are non-cardiopulmonary, so that's your non-chest pain, non-significant shortness of breath with exertion, or significant palpitations, or things that are clearly linked to the heart and the lungs, but are just still considered mild or moderate, you can do training after symptom resolution during self-isolation. And then if you have a remote infection greater than 3 months without ongoing cardiopulmonary symptoms, you can see they all branch down to no testing is recommended from a cardiopulmonary standpoint, which means if you have asymptomatic illness, mild or moderate non-cardiopulmonary, or remote infection non-cardiopulmonary, you do not require any type of testing with regards to cardiovascular testing, but it's still recommended to do a graded return to play, which we'll talk about. Now, if you have any cardiopulmonary symptoms identified by the athletic training staff and to the physician to the cardiologist, it is recommended that you do something called Triad testing, which includes an EKG, troponin, and an echocardiogram, and see a cardiologist. Any abnormality with that testing would prompt a cardiac MRI to be done. And if you do not have abnormal testing there, and if you have normal testing from that Triad testing, then you can move on to a graded exercise return to play or clearance by a cardiologist. Any pathway along this way that has a positive screening test that prompts a cardiac MRI, which screens positive for myocarditis, that would prompt you to get into a myocarditis protocol, which will leave to the cardiologist to briefly touch upon. But if you have all normal testing, but you still have persistent symptoms that are concerning, such as exertional intolerance that doesn't make sense for the level of infection and the time frame after the infection, that would still prompt an additional cardiovascular workup by the cardiologist, and they may do a stress test or a stress echo. But again, if you look at this here, these new recommendations are pretty elegant because basically, if you kind of put yourself on the left side of the screen, you know, you're going to be not really requiring too much from a cardiac standpoint, but again, a graded return to play is still going to be recommended. You go on to the other side, you have more significant symptoms, cardiopulmonary symptoms, that is, you will require some testing based on the algorithm, and that will follow through to make sure you don't have an acute or acute on chronic myocarditis. Now, I think the elephant in the room that, and this is something I'm just going to briefly touch upon as well, is that when you look at the CDC guidelines for isolation, they clearly show that the recommendation is to be isolated no matter what for 5 days, no matter if you have no symptoms or mild symptoms or moderate symptoms. So when it comes down to return to play, the recommendations of, hey, you can become active after 3 days if you're asymptomatic or after symptoms resolved if you're mild or moderate symptoms, that is again an isolation away from the team. That doesn't mean if you're asymptomatic on day 3, you can leave isolation and then go to your sports team and participate in a practice or participate in an exercise or a team meeting. So you're still isolated to that point. And that brings up the further question, which I will review, that now you're on day 5 and you're leaving isolation, but the recommendations are to still be masked when around other people for an additional 5 days. For a lot of sports, you're not able to be unmasked because you're so close to your either teammates or your opponents while you're playing. I know there's things that are completely different, such as a track athlete that's doing a solo event, or golf, or even, maybe tennis, and there's obviously other sports that fit that. But again, you would still be recommended to be wearing a mask for the additional 5 days. So that does limit, in our opinion, the student athlete's ability to be fully returned during that time frame, whether you're cardiac cleared or not, based on the new recommendations. So a graded return to play, I know this has been a topic of a lot of, this has definitely been up and down with regards to the need for it. I think everyone is in agreement that you need to do some form of a graded return to play. It can be highly individualized, but the answer after COVID with a returning athlete is never not to do a return to play. But there is some subjectivity to it based on the level and based on what the athlete is presenting with. So what I have on the screen is just a general stage that's been adopted through it's been adopted through the British Journal article that came out last year, which at the time was asking for each stage to happen during 1 day. A lot of people moved away from that, saying that, hey, we want to have a return to play after COVID. We want it to be graded, but we want it to be individualized. So most physicians are doing it in a way, and I think the athletic training staffs are doing a great job with this, is that they're looking at the individual athlete, they're seeing what they can and can't do, and they're moving them forward appropriately based on their activity tolerance, and if they're having any symptoms, modifying that plan and re-getting physician's team involved if necessary. So I'm not going to go over the whole chart, but I just want you guys to be aware that no matter what, if you have COVID-19 and you have a student athlete post-COVID-19, no matter if asymptomatic or moderate or even severe symptoms, there needs to be a graded return to play. and it should be individualized. Some of these individuals may not need to go into a stage 2 immediately. They may go into, if you look at the left, the stage 3. They might even get into moderate activity initially. The key thing is medically supervised, graded return to play that fits the athlete's need. So full competition return, and this is something that we do from a system level, including our Division I sports contracts as well as our other sports contract. But basically, we don't recommend the student athlete go to full unrestricted competition any earlier than the 11th day after the sample is collected or the diagnosis, or the 11th day after the physician determined date of symptom onset. The reason for that is simply because the recommendation is still to be masked from day 5 through 10, and the mask comes off after that, which is your day 11. I understand this is not going to be fully applicable for everyone. There's going to be athletes that are able to, probably do this sooner, but as a general consensus, if you're playing a team sport, and this is definitely open for conversation, it is really hard for someone to be masked during that time frame, and playing a sport at a very, very high level, based on what that person is doing. So because of the isolation and the masking restrictions that are still in place, that's what we currently are recommending. And we know, and I completely get it, that there's professional organizations that have guys returning on day 6. But again, that's not in alignment with being able to stay masked and not prevent illness spread. There is still viral shedding that can be going on during that time. So from a public health standpoint, this is still about preventing the spread of illness. Return to play progression following isolation or quarantine for COVID should be individualized and supervised. We recommend that's done by the institution's athletic medical staff. The cadence of that return, again, can be highly individualized based on a graded return to play. It just needs to be applicable. That becomes really important because usually what happens with the case of myocarditis initially is that as the athlete is becoming more active, there could be an up regulation and up activation of the virus within the myocardium of the heart. And as you're increasing your workload of the heart, you can actually increase viral production and actually worsen the actual infection. So a lot of the times you may only have minimal symptoms that may be overlooked in a very, very elite, well-conditioned athlete. But then by the time they're starting to get on the treadmill and move again, they're developing these really significant cardiopulmonary symptoms that we require a cessation of activity and then a prompt medical evaluation by a cardiologist or physician. And that's the last bullet point there. So our experience is really briefly, we're really proud. We have a great physician team, and we worked really hard on getting together some research that we did. And our article, Post-COVID-19 Cardiovascular Evaluation and NCAA Division I Athletes, is going to be published soon in the Clinical Journal of Sports Medicine by all the authors there. And our takeaway is that in our experience, and I'll let you guys see the article when it comes out, but basically we did not have a single case of acute myocarditis in the patients that we actually did cardiopulmonary screening on after COVID-19 at our Division I university. And I think and we were doing very aggressive testing. We were actually doing EKGs, troponins, echoes, and cardiac MRIs initially for quite some time based on Big Ten recommendations. And then as the consensus changed, we were able to par down on some of that testing. But again, we did not have a single case of acute myocarditis, and that is different than other universities who actually had several cases of acute myocarditis. So more to come on that, but our research actually does fit really well with the 2022 ACC consensus guidelines. So I'm happy that our cardiologists will be following them. And this to references from the CDC and again the ACC expert consensus guidelines. So with that said, I do want to pass. I'm going to close out the presentation here, and I want to get our panel involved, Dr. Altobelli and Dr. Lander, to do a panel discussion, and then we can do our Q&A.
Dr. Kostofiak, you did a great job. outlining the latest recommendations and updates, breaking it down in a nice, easy manner for all of us to follow. So I think we're on roughly our third iteration or so of kind of evaluation and return to play guidelines. I know that we may find it frustrating that it's changing, but I actually look at that as a good thing, because what that means is it means we're evolving as we learn more about COVID-19 and how cardiac sequelae and other sequelae we may see, and what we need to do to get back safely onto the field as quickly as possible. In the very beginning, what our initial experience, which I'm sure Dr. Altobelli can attest to, is our patients we saw in the hospital, they were sick. They were really sick, these patients in the hospital, and there was a very high incidence of cardiac involvement. And as we looked at that and we turned to our athletes, we got nervous. We say, if there's this high incidence in these hospitalized patients, what does it mean for our outpatients who are getting COVID, and then we want to get them back playing competitively at high levels? So we started off pretty conservative with those return to play guidelines. And as we learn more, as we evolve, the next set of recommendations were a little bit less conservative, et cetera, to where we are now, which is probably the least conservative of the group. But that being said, even though timing may change and how we test may change, and as we go forward and learn more, I'm sure it'll change again, I think it's always important to remember that we do see incidences of cardiac involvement, whether that be myocarditis, which is probably the one we worry about the most, or other cardiac issues. So it is important to keep a close eye on our athletes and evaluate them appropriately, and part of that graded return to play is so we can do just that and keep a close eye on the athletes to see, are they able to return safely, and are they having any symptoms that may be worrisome upon that return to play.
Yeah, Jeff, I think those are good comments. I think what everybody needs to realize, two things. This is both a patient health issue as well as a public health issue. And I think the frustrating part of this for athletic trainers and for coaches, for athletes and their parents, is that they see young people getting COVID relatively asymptomatic, but yet they're requiring isolation. They're allowed to return to exercise within 3 days, but then they're required to mask up. So look at it two ways. You have the health of the patient, which for most part in young athletes, particularly in high school, they're not going to have any sequelae, cardiac issues, pulmonary issues from COVID infection. But I think Jason highlighted the fact that there's also the public health issue. By wearing the mask, you're preventing transmission. And I think that that's important, but nonetheless, I can understand that it's very frustrating for everyone involved. So protect the athlete, but protect those around the athlete. I think the other point I would make, on a bigger scale is, it's not just about the athlete. It's not just about the team. It's also about the school. It's about the district, and it's about the parents. So for our high school athletes and for those on today's call, I think that, while we want to be good stewards to the athlete and to the team, there are other people involved. And I think one of the more sensitive issues also is parents, both those pushing to get their kid back on the playing field and those who are hypervigilant and are concerned. I'd probably like to also make a statement about graded return to play vis-a-vis the comments I just made. Many of these kids are not symptomatic, and those that may are probably only going to be mild, although I will echo with what Jeff said. During the pandemic, we did see 20 and 30-year-olds on ventilators in the hospital. And when you walk in and you look at the profile of some of these younger people, you say, how did that happen? Because there were people in their 20s and 30s who had no significant comorbidities were affected. And I can, relate one person who was one of our cafeteria workers in his 30s at Robert Wood Johnson University Hospital who did actually pass away from COVID. So we have to also keep that in mind. But when we talk about graded return to play, let's say you decide, I'm not going to do graded return to play. Let's just get them back on the field. You do run the risk of the following. If they had mild symptoms or no symptoms, and you put them back on the athletic field and tell them they can go 100%, they may develop some symptoms because they're deconditioned. And now you're in a tough spot, because are the symptoms because they didn't have a conditioning program to get them to 100%, or are the symptoms a result of something maybe due to the viral infection? So just a caution if you think that we should just push them back to 100% without the graded return to play. I think the graded return to play is common sense because it also allows us, as we increase the workload in the athlete, make sure that they don't have symptoms that are not attributable to deconditioning, but potentially due to the coronavirus. And another comment I'd like to make, what are we concerned about? I think very simply, we're concerned about myocarditis in the athlete. So viral infection and viral multiplication in the heart can lead to myocarditis. Myocarditis is an inflammatory cascade that occurs in the heart muscle, and it leads to heart dysfunction. It can lead to compromise of heart pumping. But the other big issue is, we know from prior studies in decades past that athletes who have myocarditis are at risk for electrical disturbances, arrhythmias, and in particular ventricular arrhythmias. And ventricular arrhythmias can lead to sudden cardiac death. So that's why all of this came about in athletes. You're not so much concerned in a non-athlete, but when you put somebody out there who has myocarditis and you exercise them, and if the myocarditis is clinically significant, you're at risk for arrhythmogenesis and sudden cardiac death. And again, I think that's, some people on the call are saying, but listen, you just told us that in your experience, you didn't detect myocarditis in any of the athletes that were screened. And again, I think that's the challenge here. You don't want to have that one case. And the probability of having that case is probably extremely low, but it's not zero. And then that gets back to my original comments. We have to be stewards of not only the athlete, the team, the school, the district, and the parents. We have to take everyone into consideration. And I think that kind of hopefully I've given you some sense, a common sense approach, to the whole problem that we're faced. And as Jeff has said, things continue to evolve, and we don't know if the next variant will be as significant as the Delta variant, and perhaps this will just peter out and become endemic, and it will become an annual flu shot for us. But until we get there, I really would support all of you following these guidelines, including isolation and graded exercise and return to play.
Hey, thanks, Anthony and Jeff. I'm going to answer some quick questions, and then I'm going to go back to have the panel answer some of our other questions as well. So one of the questions came in that, are you okay with an athlete if they're comfortable practicing in a mask? So going back, so we have your isolation for 5 days, and based on the new ACC recommendations, if you have no symptoms, you can get moving as early as 3 days. And that's, again, you're still in isolation. So for me, that means that person is doing individual exercises in an isolated fashion, either home or in their backyard, or completely away from everyone to prevent spread of COVID. Or it is after symptom resolution if you have mild or moderate symptoms that without cardiopulmonary features, again, within that isolation time frame. So this mask wearing question, I'm going to take it to be into that 5 to 10 day range. The short answer is I'm against that. I've just seen some people wearing the mask and trying to go full force during that 5 to 10 days, and their outcomes have been anywhere to worsening symptoms, to spread of illness, and actually, passing out essentially. So we do encourage that based on the guidelines, after you leave isolation, Can you get moving individualized in a safe manner without the spread of illness? I do believe that to be the case, but I do not recommend a mask during that time. And if you're not wearing a mask, you really shouldn't be around your team, in team meetings, doing travel. Again, the basic things about not spreading the illness. My 2 cents is I personally think that around the country and even in New Jersey that the rates of COVID are actually higher than where we know. I think the use of home tests are kind of clouding the actual true number of COVID-19 cases. That's not going to take away the merit, the fact that the vaccine is doing a great job of and doing exactly what it's meant to do. Keep people from having a poor outcome from COVID, such as, long-term complications and death. But again, I still think we have a due diligence of not promoting the spread of illness because we want to be involved in a sport. And I think it's been a very challenging line as a team physician to manage that. But again, I think we're all doing the best we can. So that's my short answer on that. And their great question was, with a graded return to play, the British Journal article recommended it be done in days. So we're looking at our concussion return to play. We have stage 1, stage 2, stage 3. Each you have to go on by 24 hours. The question was, can you do multiple stages in one day? Short answer to that is yes. The idea would be, as long as you're doing a graded return to play, and in our medical opinion, you can do multiple stages in the same day. However, you need to keep a really close eye on them, and this is a medically supervised return to play. So if it's not being supervised by the physician, athletic trainers, coaches, who's ever involved from the institution, it needs to be supervising this return to play, and any symptoms that are concerning for our cardiopulmonary patient that needs to exercise participation needs to be stopped immediately, and there needs to be a reevaluation. There was a comment about individuals who have not tested positive for COVID, but then people have required them to see a cardiologist for testing just because they've been vaccinated. That is not recommended by our institution. I have not seen any reliable papers. I'm assuming that's coming from some data that there's been some incidents of myocarditis in people that were vaccinated. And I know there's some papers and studies out of Israel and other locations. But currently, if the only way you're getting put into this protocol that we're talking about today is if you have tested positive knowingly for COVID-19. So if you have not tested positive for COVID-19, there really should not be any workup because you're vaccinated. Now, if that person got vaccinated and then has cardiopulmonary symptoms afterwards that are new, then absolutely that person needs to be seeing a cardiologist, but the algorithm presented today is really not applicable. We'll leave it to the specialist to decide what is going on and what else testing needs to be done. Getting back to our panel, for Jeff and Anthony, how do we know when not to do advanced imaging / testing in our athletes? I think the algorithm kind of touched upon that, but if you guys can touch upon it from your specialty end, the question is, hey, when do we not do a cardiac MRI or additional testing?
It's a good, relevant question. So again, dating back to when this all first started, so the reason we started doing this advanced imaging, advanced testing stemmed early in the pandemic when we saw these, like we talked about before, saw these cardiac complications of COVID-19. And I think it was a German study, they started doing some cardiac MRs on these hospitalized inpatients and saw there was cardiac involvement. So that made us nervous, and there was a bit of a rift within the medical community about what to do next. Should we do MRIs on everybody? Should we not do MRIs on everybody? And so one of the things that we saw that Dr. Krzysztofiak mentioned in the study that we did MRIs in everyone who was testing positive for COVID-19, and there was no myocarditis that we found. And similar studies and registries that have looked at both professional and collegiate athletes have found very similar findings. It's generally under a 1% incidence of myocarditis. There are a couple of outlier schools in the Big Ten study that was a little bit higher, but a lot of the other big studies are showing under 1% incidence. So really what we're focusing on now, that the latest recommendations show that Dr. Christofiak covered, is if you have asymptomatic, mild, or moderate symptoms, there's really no need for more advanced testing. It's really only those athletes who are having cardiopulmonary symptoms, chest pain, shortness of breath, palpitations, passing out. These are some of the big ones that we look for. And it's important to remember it's not just that initial presentation where they have these symptoms, but I want to stress this is also the importance of those graded return to play. Because if we're seeing these symptoms de novo or not going away on that return to play, that might prompt a cardiac visit and more advanced testing.
Yeah, I would add to that. When you think about early on, what we really were doing was screening, right? So screening is you're not sure if a population has a disease, so you're going to do a test on everyone, regardless of how they present. And that's why cardiac MRIs were part of that evaluation as a screening tool. First, myocarditis. We know other coronaviruses cause myocarditis. SARS-CoV-2 was not the first coronavirus to cause myocarditis. We were very well aware of that. And I think that's what prompted screening until we found out that the incidence was extremely low. I think I would, for somebody who has symptoms and who goes on for testing, I think it's probably worth pointing out that Triad test that we do. The first thing is we do a 12-lead surface EKG. So that's a good screening tool. It's cheap, it's fast, and it does yield some good information. So you could potentially pick up some electrical abnormalities on an EKG that could signify myocarditis. The second thing we were doing as part of that testing was an echocardiogram or a cardiac ultrasound, which lets you directly visualize the size, structure, and function of the heart. Conceivably, if somebody has myocarditis and symptoms, you could potentially see an abnormality on the echocardiogram. And then the third part of that triad of testing is a troponin. A troponin test is a blood test that looks for a protein in the heart muscle, in the heart cells, called troponin. When the heart cells or muscle gets inflamed, cells die and release troponin into the bloodstream. And that's a very sensitive test for the detection of heart injury. So even though an MRI sounds pretty fancy, and quite frankly, it is fancy and it's expensive, if you combine an EKG with an ultrasound with a blood test, that's a pretty damn good evaluation to start with for somebody who's having symptoms. And if those three tests are normal, then I think you're okay. And that's what the experience has borne out. And Jason, I'd like to also make a comment. We also need to be practical in medicine. And I think gets back to the question, well, can you mask after day 5 and go back to the sports field? I'm going to say athletes and potentially coaches, there's a challenge to exercise good judgment. Again, in the sense that most athletes are not going to have any problems if they get infected with COVID. But the problem is, as the athlete who is a recreational athlete moves into a competitive athlete, and the competitive high school athlete who wants to win and or wants to play in the NCAAs, and the NCAA athlete who wants to try to get into the professional field, putting a mask on somebody and saying, hey, go back to the field, but take it easy. I mean, in general, I don't think that's the nature of an athlete. The nature of an athlete, to the contrary, may be, I have a mask on, but this isn't going to inhibit me in any way. And essentially what you're doing is adding more stress to the body, because essentially what you're doing is, I don't want to say you're depriving that person of oxygen, but the work of breathing is harder with a mask on. And I think there's an innate drive in any athlete to overcome any barrier and perhaps not necessarily recognize that that mask is going to challenge their physiology and maybe not use the good judgment. So I would agree with Jason about masking the athlete and letting them go back to the playing field. And I would not advise that.
Great. We have some great comments and questions. Just going to touch upon a couple of them and pass them on to the group as well. So what if someone has tested negative after their day 5 isolation? Does this change the recommended return date? It's a great question. Very, very, very controversial. So our 2 cents is as follows. So yes, I know that especially in Power 5 conferences and professionally across the country, there has been institutions that have been doing testing right after that day 5 return, and if they're negative, basically having them go forward. COVID is over, no more masking, whatever your cardiac policy is institutionally, and just that's it. You're moving forward. Great idea, but a couple things. There's really no recommendations from a public health standpoint to be retesting people after day 5. So looking at that standpoint, taking away the team physician role for a second, now we're basically just utilizing a lot of expenses and doing a lot of testing and taking away testing supplies that we could be stockpiling for the next outbreak. That's more of a public health standpoint. More from a practical standpoint, and I've seen this quite several times, and this is what scared me, that kind of prevented me from supporting that type of plan, was that sometimes with COVID and other viruses, you can actually get rapid cycling of your viral load. And it's always been debated about, hey, what viral load and amount of shedding do you really need to pass this along to somebody else, especially with the differences of transmission. So I've seen someone who we tested on day 5 and they were negative, and then they felt a little different on day 6. And for educational purposes, we retested and they were negative on day 7. They were positive, and day 8 they were positive, day 9 they were positive, and day 10 they were still positive, and day 11 they were negative. Right? That's a lot of false positives in a row. That's probably not the case. So that person was like, did you have a false negative initially? Did you have a false positive afterwards? You have to really question that. The answer usually becomes is because we're doing PCR in these people. We're not relying on rapid antigens, right? So we're doing PCRs and we're getting actual data from that. And usually when you look at the cycles, it just seems that there was this variation in the amount of viral load that was being detected by the PCR. So that person was still positive and able to pass it along. And we would not know that unless we tested them every single day up until day 11. Again, that was educational. I know I just said don't do that because we're wasting resources, but just to clear, that was an educational thing. But we did follow several athletes who fit that profile. So it is a kind of a little bit of a toss up there. Where you feel most comfortable with your testing? Do you have the resources to do so? And are you really sure that person is not infectious between that time frame? Because personally, I haven't seen anyone spread illness after day 10, but I've seen plenty of people spread illness between days 5 through 10. So anecdotally, that's at least what we're doing. Institutionally, I'm sure as more information comes out, we're definitely be willing to, change the stance on that. But the short answer is I don't recommend doing that. Again, I know that there's conferences and other people that are doing it. I'm not talking against them. I have just seen the other side of the fence where that there has been spread of illness. And in one case, someone who I believe through contact tracing actually got it because of this scenario, ended up needing to get a cardiac workup, and their cardiac workup was incidentally abnormal. And then they went on to get a cardiac MRI. Long story short, weeks later they returned, but they literally missed 3 weeks of playing a sport, which likely wouldn't have happened if things were done a little bit differently with that 5 to 10 day testing. So great question though. Let's see here, looking through, had a really good comment about just indoor spread that they felt between wrestling and basketball, but they really haven't seen any outside spread. So maybe ventilated areas, poorly ventilated would spread, maybe less, more ventilated with less spread. Those are great points. I struggle with this. If you have a golf athlete, can they return on day 6 because they're going to be out golfing, possibly by themselves or very, very socially distanced? I don't find that the spread is coming from the direct contact. For example, a lot of the contact tracing I did with football, I did not find the spread to be field to field contact. I actually found the spread to be more locker room, incidental, people driving together, conversations on the sideline, on mass. I think it's really challenging for that athlete to be 100% masked, except for the actual times of doing physical exertion. The incidental times with meeting with coaches, going to get water, eating in between a snack, going for lunches, that's when we're seeing most of the spread. So I agree. I'm not seeing a lot of spread through contact tracing, sport to sport, except for, I think, wrestling, we saw a fair amount of that. But otherwise, it is really challenging between that day 5 and 10 to really say that you're doing a great job of preventing the spread of COVID if they're not going to be masked and if you're putting them in an athletic situation. So great comment. Let's see here, going through. It's common for the group. It's really good, really applicable. So if we have a high school athlete that develops symptoms, and let's just say they're developing cardiopulmonary symptoms and they need to see a cardiologist, but hey, it is really challenging sometimes to get in to see a cardiologist. Do we recommend they go to the emergency department to be seen more acutely? Like what are you guys getting from your end? My quick comment is if the person is having acute cardiopulmonary symptoms that are really concerning and they look like they're sick, they need to be evaluated acutely, no matter what the case. But if we're talking about someone who had an exertional intolerance that subsided immediately they stopped exercising, the question is to Jeff and Anthony, like, what should they do if it's going to take a while to see a cardiologist?
That's a hard question to answer, to be honest. I agree. Any kind of acute symptom, like you mentioned, that's concerning, acute chest pain, shortness of breath, passing out during exertion, those all warrant ER visits, seeing somebody rapidly. Otherwise, this is more. It's hard to answer because our healthcare system is strained, right? So we saw this with the pandemic. There's big strains on the healthcare system, and this is part of the reason we talk about appropriate testing and not over-testing and not over-utilization, because the more one person takes from the system, it limits what someone else may their access to the system. I don't have a great answer on what to do, but I would say if they are having symptoms that are new and or different and or worsening, they do need to be evaluated, and we really should hold them back until they get that evaluation.
Yeah, I mean, I'm a big fan of not using the emergency room unless this is these are critical symptoms. I think if the question is access to cardiology, I could tell you I had some athletes from the Philadelphia schools come up because they knew of me through my sons who were high school athletes because they had access issues down there. I think working with Diana and our team, we can get these kids in to be seen. Now, the question really is, when I say kids, now, part of it is because I'm an old man, but the other part is, what is the cutoff for pediatrics versus adult cardiology? And I will tell you, I will see 17 and 18-year-olds. But when you start getting into 16, 15, or 14-year-olds, I think you fall within the realm of pediatric cardiology. Down here in New Brunswick, we do have a good group of pediatric cardiologists. So you guys will have access to, our health system, and we're here to support you in that regard. So Diana would be your point person. I've elected her for that. And, we'll get the kids in to be seen. Okay. We'll make sure that we can offer you that.
Dr. Altobelli, thank you for self-selecting me. I was going to volunteer my services anyway, but
Good.
we also have pediatric cardiology resources in our area as well. So I would say statewide, we're pretty well covered. Don Putman, as well up north, has supported, a lot of the cardiac needs for us for the little ones. So if we have some middle school athletic trainers on, we can pretty much cover all your needs.
Yeah, and it would be based on geography. I mean, if you're a school down in Middlesex County, we'll get you to somebody, locally at Robert Wood. But again, with a large health system with thousands of healthcare practitioners, we'll make sure we accommodate you based on the geography of the student athlete.
That's really great. There was another question that came through. Let me just find it. Basically, it was asking for a greater return to play if you have an athlete who's several months out, had COVID, maybe asymptomatic, whatever the case would be, and you're finding out about it a couple months later. Do they have to do a greater return to play? Based on the new ACC consensus agreements, if you look at the algorithm, it basically says if you have history of COVID that's been a while and you're completely fine now, yeah, there's no testing involved, but there is still a greater return to play. Again, the recommendation is you can make that highly individualized. You do not have to sit them out for weeks and doing, something extremely tedious. But just if you're an athletic trainer, just get your hands on them. Everyone, you guys know your athletes. Get a heart rate, get some basic stuff, get them moving, start out light, get them move, and advance from there. But just do your best to do some form of a graded return to play. You never know what symptoms can pop up. That brings up another good point. There has been more cases about long-term COVID individuals, people who've had COVID for symptoms of COVID for many, 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 many months. And the question is what to do about them. Great question, really challenging. I'll leave to Jeff and Anthony to kind of close the door on that. But it's one of those things. If you have prolonged symptoms of COVID that are lasting, right? And you're going through, different cardiac testing, they're all normal, but then the individual is still not ready to get back because they're having prolonged symptoms of COVID. That, in my opinion, becomes more of a exertional or intolerance issue, maybe not related to a cardiopulmonary issue, but just related to the sequela of a virus in your body. And I think that's really challenging, and that's something that probably needs a multidisciplinary approach, multi-physicians between primary care, between pulmonology, cardiology, maybe infectious disease, rheumatology, who knows? There could be other things peeking through, and that person likely needs a very formal and very thorough medical evaluation to make sure nothing else is, contributing to that. But from the cardiac standpoint, I'll let Jeff and Anthony comment on long-term COVID.
I think you pretty much hit the nail on the head. For any, speaking strictly about this kind of post-acute sequelae or long-haul COVID, any cardiopulmonary symptoms need to be evaluated and investigated first. If cardiopulmonary testing is done and everything, see no obvious abnormalities there, that's when we turn to this multidisciplinary team. So this long COVID is not fully understood yet. There's several possible underlying etiologies to it, and those are still being hammered out exactly what it is. We don't have a great answer why. We have speculations on different things it could be. Could it be autonomic dysfunction, et cetera? But just like Dr. Krzysztofiak mentioned, at this point it needs to be referred to a multidisciplinary team. And we're fortunate at RWJBarnabas Health. We actually have this long-haul COVID program where the primary care doc work with the cardiologist, the pulmonologist, the rheumatologist, the ID doctors, and you get pretty comprehensive care. And my experience working with that group is they're really on top of the latest recommendations, the latest therapies, and it's a great resource to utilize if needed.
Yeah, it's always a challenge when subjectively the patient feels poorly and objectively all the tests come back normal. And I think that speaks to this is an area of active interest with research. We're also looking at the neurocognitive outcomes too. You may have an athlete who just says, I'm fatigued. I can't do what I'm used to doing. And it may not just be a conditioning issue. Again, and that's where there needs to be a kind of a multidisciplinary approach to the care of the patient who subjectively feels poorly, but objectively all the tests are coming back normal.
Great. Let's see here. Maybe one last question. How many long-term COVID patients also test positive for Epstein-Barr, Lyme, or other tick co-infections?
I don't have experience there. I would probably defer to infectious disease. You know, it's interesting you mentioned Lyme disease. There is a group of physicians and patients who believe once they have Lyme sequelae for the rest of their lives. It's almost become a little bit of a cottage industry. An infectious disease doctor will check them and say, listen, there is no signs no objective findings that you have blood testing consistent with Lyme disease, but these patients have significant debilitating symptoms throughout their life that they attribute to Lyme, not just the prior infection, but they feel that they're still infected. And I think that, you know, now we go into the neurocognitive and the psychiatric realms. Right now, though, I don't think that there's, you know, contracting SARS-CoV-2 increases your risk of getting Lyme disease or Epstein-Barr virus. But some patients, though, who do get these infections do have long-term, in my clinical experience, neuropsychiatric issues later on in life. And I have some patients now who've had COVID infection, and objectively, all the tests are normal, but they are so disabled. And right now, is it a physiologic disability or is it a psychiatric disability? And I think that that's something that we're going to need to continue to explore long term.
Great. Closing thoughts, and I think then I'll pass it back on to Jess and Dan. I think that this was really great. Audience, really great questions, a lot of engaged. A lot of the stuff is really controversial, right? And really at the last closing advice for me would just be like, hey, if there's a lot of institutions that are on today that are doing things a little bit differently, and that's completely okay. The recommendation is just, you know, make sure you're following a policy, make sure you're doing right by the student athlete. If there's a concerning features, get them further evaluated. Don't be a cowboy with it. There's still a lot that we're learning, and yeah, things are looking more promising, but again, I think that everyone on this call throughout the whole entire world is really, you know, dedicated and sacrificed a lot during the pandemic and really trying to do what's right for the student athletes to continue playing sports. It's not only physically healthful, it's healthy, it's behaviorally healthy. There's so many different facets to this. But at the end of the day, you just follow protocols, stick to it, you know, you can use clinical discretion, you can move things around a little bit, but at the end of the day, if you're following something like the 2022 ACC consensus guidelines, if you're following a graded return to play, knowing you could be a little bit more aggressive and individualized with one athlete, but then be a little bit stricter on another one, that's completely fine. But at the end of the day, remember, utilize your expert consultation. Always remember to ask questions. I wouldn't push anything forward in a solo fashion unless you're absolutely sure. And then again, even at the physician level, we're still asking questions all the time to each other to make sure we're doing what's right for the student athlete, and try not to let personal bias kind of have a play within that protocol, right? Whatever it is, whether you're like, hey, we need to get vaccinated every single year for the rest of our lives versus I don't think we need to do that. That's completely fine, but let's just let the best medical evidence we have up to date, let's all try to agree that we're going to do our best to follow it. And I think we'll be doing a really good service for our student athletes moving forward.
Well, I want to thank everybody for joining today. Our panel was amazing. You guys just made some really good points. I think you got our athletic trainers across the state of New Jersey really thinking about what they're doing day to day. And certainly, please know that we're always available for follow-up questions. We know there's a lot of questions as it relates to this topic, and I'm really, really happy we spent so much time covering questions. I think it was essential for this program. Please, just a reminder, keep a lookout for your surveys coming from your ATSNJ reps, that you should see that coming out in the next few weeks. And then just one final announcement. I know we have some frequent flyers for our programming. We will be doing a sports medicine grand rounds program in June on the female athlete that we're really excited about. So please keep a lookout for that as well. Otherwise, everyone, please have a great day, and we'll see you again soon.
Take care.